Hello, and welcome to today's webinar on the Wellbeing Index and how to reveal burnout in 9 questions. We're so happy you could join us as we dig into the functionalities of the Wellbeing Index and discuss how institutions across the country use it to assess the wellness of their organizations. My name is John McMahon, and I'm a solutions architect here at MedEd Web Solutions. I'll be moderating today's webinar and fielding any questions or comments you may have about the Wellbeing Index. As we get into the presentation, we do encourage you to ask questions. You can do that by using the Q&A button at the upper left of the video window. A new window should open up and you can ask your questions and see your answers there. Just a few reminders as we get started. You'll be receiving a recording of today's webinar via email following the presentation, and we will receive a contact information for any follow-up questions as well. We also encourage you to go to mededwebs.com and try the Wellbeing Index demo for yourself. So with that, it's time to get started. I'd like to introduce today's presenter, Alan DeCarroll. Alan is the owner and Chief Happiness Officer at MedEd Web Solutions and has worked side by side with Mayo Clinic for the past 3 years on the functionality of the Wellbeing Index assessment tool. Alan, take it away.
All right, thank you, John. I appreciate that. As the Chief Happiness Officer, my day is often brightened by people who will simply reply to me email and just say that they love my title. I guess it's the little things during the day that makes you smile, and that's why we're here today, is try to figure out how we can bring a little bit more happiness into the healthcare industry. And I appreciate you taking the time out of your day today to learn more about the Wellbeing Index. We have close to, looks like almost 100 people on the call today, so that just shows me how much institutions care about this problem and really want to make a change. So what we're going to do today is we're going to talk a little bit about who is MedEd Web Solutions. We get this question often about, wait a minute, I thought this was developed by the Mayo Clinic, and who's this MedEd and how did you guys get involved? So we're going to talk a little bit about that. We're going to talk a little bit about some statistics around the well-being problem and the burnout problem. And after that, I'm going to hop out and I'm actually going to demonstrate the Wellbeing Index for you from both the perspective of a physician, what it looks like for them and what they experience. And then I'm also going to show you the back end, the administrator side. So you as an institution, if you license the tool, what type of things you can see and experience and what kind of data that you can collect. And then after that, we'll come back to this presentation slides here, and then I'm going to show you some ways that you can get involved, some free ways and some ways that you can license the tool if that's of interest to you, and how you can be involved in this mission to hopefully reduce burnout. Now, before I begin, I'd like to disclose that much of what I'll be sharing with you today is based on research and findings of other people, especially Dr. Shanafelt and Dr. Derby at the Mayo Clinic. These two are the inventors of the Wellbeing Index, and they have dedicated many years of their career to bringing the WBI to life. So I'll share a story shortly of how it came to fruition. But in the meantime, just know that I may appear smarter today than I actually really am. With that said, I lead this amazing team from MedEd Web Solutions. And so, like I said, the common question is who are these guys? The Mayo Clinic is the one who developed the tool. But they did that for their own purposes initially. So Dr. Shanafelt and Dr. Derby developed the index, developed the tool, because Mayo wanted a tool essentially to assess, the well-being inside their institution. But a couple of years later, they had so much interest, they'd go out and talk about the topic and what Mayo had been doing and some of the successes that they had had. And people said, that tool sounds fantastic. Can we use that tool also? So Mayo Clinic in turn turned around and licensed it to MedEd Web Solutions. So we were the web and the application development company that actually worked with Dr. Derby and Dr. Shanafelt on the first version way back in 2014. We're based here in Rochester, Minnesota, obviously near the Mayo Clinic. And so for the last 10 years, we worked extensively with departments at Mayo Clinic on various projects and initiatives that they've had. So let's begin to talk a little bit about why we're here today. And that's how burnout is affecting many of our healthcare workers. The reality is that the majority of physicians feel that their workload is too heavy, and essentially that their family and their personal lives are suffering because of it. In fact, less than a third of physicians actually feel that their work schedule leaves them enough time for their personal and family life. Part of this could be due to the nature of the physician's work environment, what they experience day to day. It's often a hostile work environment with excessive demands on their time, a very chaotic pace throughout the day. And really, the physicians have limited control over input variables throughout their day as far as how their day is going to go. And sometimes, depending on how big of an organization they may feel a sense of isolation. So this and other factors, which I'll discuss shortly, have all led us to know and love this term called burnout. But what does it really mean? Well, burnout is a symptom of depersonalization, emotional exhaustion, and low personal accomplishment that leads to a decreased effectiveness at work. But if we look at that a little bit closer, we see that the word, depersonalization is essentially them beginning to treat individuals like objects instead of patients. So they become deconnected from the person and their problems. Emotional exhaustion is essentially losing enthusiasm for the work that they do. And a low personal accomplishment essentially means that they're starting to lose the sense that the work they do has meaning, or that they don't have this feeling that they're being very effective in the work that they do. Now, we also know that burnout among US physicians is much higher than other US workers. So it's not just a problem across the entire US that this is a problem that every type of industry is experiencing. In a 2013 study of the general population versus physicians, it showed the burnout rate at 38% at that time for physicians, compared nationally to only 28% for US workers. We also learned that from 2011 to 2014, that number increased 10% for physicians and decreased for the general US population. So we can see that the problem seems to be getting worse for physicians and better for the general population. We also know that the burnout rate among physicians, it varies widely depending on their specialty. National studies are now suggesting that 45, 50% of US physicians are experiencing burnout. But as you can see from this chart here, the rate among emergency medicine physicians is well over 50% at the top of the graph there. And the burnout among, say, dermatologists at the very bottom is closer to 30%. So we know that it will vary widely between specialties, and oftentimes in our data, we may see that it varies widely between different departments and different locations. In simple terms, Dr. Shannenfeld has categorized the drivers of burnout into 5 dimensions. Those include workload, efficiency of work, physician autonomy and flexibility, their work-life integration, and their sense of meaning in the work that they do. But to make matters worse, these 5 dimensions are also compounded by other external factors, such as personal factors like their family, work group factors, hospital institutional factors, and also national factors like we have going on right now with the national healthcare policy and how that's going to change the work that they do. So we know that burnout has professional consequences for the physician and also the institution, such as reduction in patient satisfaction, a decrease in professionalism. They may reduce their hours or seek alternative professional roles. And burnout is also associated with an increase in medical errors. Actually, in a study of US surgeons, 9% self-reported that they had made a major medical error in the last 3 months. And as we know, medical errors lead to additional distress, and additional distress can lead to an increase in medical errors. But along with professional consequences, we also have personal consequences of burnout, such as an increased cynicism, a loss of commitment, a loss of meaning in the work that they're doing, and probably most concerning is an increase in suicide ideation. In a study of US surgeons, 6.4 had thought of suicide in the last 12 months. Now, that might not mean this may not need to be mentioned either, but depression is the strongest variable in correlation to suicidal thoughts. So as you can imagine, when Dr. Shanafelt and Dr. Derby were studying this problem, a few years ago, probably almost 5 years ago now, they wanted to help Mayo Clinic reduce burnout and increase engagement. There were lots of tools that were available, such as the Maslach burnout inventory. There's a survey for suicide. There's a survey for depression. But we all know that physicians are already over-surveyed, and they figured that if they could just take a qualifying question from each survey, they would have a relevant tool to predict overall distress. So essentially, they took the best question from each survey, the one that the majority of the people who answered this question this way, they were depressed, they were burnt out, they were suicidal, and then essentially turned them into yes or no type questions. So with that, the Wellbeing Index was born as a simple 7 or 9 question survey in an effort to predict the risk for distress, track physician well-being over time, and provide access to timely resources. So our goal is to hopefully move them from a pre-contemplation stage to a contemplation about the status of their current well-being. And we feel that comparing them to their peers, and whether that be national peers or peers at their organization, is an excellent and effective way to do that. And probably the most important factor of the WBI is that it's 100% anonymous and it's administered by a third party. So we take away that fear that by participating, there may be ramifications for that at the institution. This allows them to answer truthfully, and it benefits both the physician and the institution because they get honest answers. Now, the first important pillar of the Wellbeing Index is the anonymous survey of 7 or 9 simple questions. This allows the physician to get immediate feedback on their well-being compared to their peers, and the ability for them to track their well-being over time. Now, it's important to note that the Wellbeing Index is not a diagnostic tool. It simply predicts risk towards several dimensions. Now, those include fatigue, depression, burnout, anxiety, stress, mental physical quality of life, and work-life balance. So while there are excellent tools for surveying and predicting burnout alone, such as the Maslach burnout inventory, we feel the Wellbeing Index does a better job at predicting overall well-being across several dimensions. And most importantly, it's not just a one-time survey. It's a lifelong tool that they can use to continue to reassess over time. The second important aspect of the Wellbeing Index is what we call just-in-time resources. After we give the participant their well-being score and how they compare nationally and to their peers, they can then access the resources. We have 11 different categories, everything from stress and resiliency to fatigue to alcohol, substance abuse, and money matters. We have all those different, each one of those categories has a video that's either been done by Dr. Shanafelt or Dr. Derby on each topic and how it relates to that person. So there's different videos for the nurse version versus the physician version versus medical student version. So really speak to that audience and address their particular needs. It's also important to know that those who choose to license the tool can also add in their own local resources. So if you have links on your intranet that are relative for well-being, if you have PDFs, and then of course things like your EAP phone number. So if they need to get a hold of some assistance at your location, that they can do that. And finally, the third pillar to the Wellbeing Index is institutional reports. While the WBI is 100% anonymous, we do give those who license the tool access to de-identified aggregate reports so that you can get a feeling for how well your physicians are doing. By default, we provide reports on the percent of physicians with a high level of distress, mean score by gender, mean score by specialty, the years since graduation. And we also show you which resources have been most commonly accessed. So we'll show you that, hey, stress and resiliency is by far the most common area that people are accessing. And you can then use that data to help you build in which types of resources you'd like to provide at your institution. And we do that hoping, to give you feedback, hoping that you'll use that data to identify your most at-risk groups and implement wellness initiatives within your organization. Then as those programs are implemented, your leadership can continue to review mean scores over time and check the outcomes on your efforts and as far as how they're improving. So before I jump out and begin our live demo of the Wellbeing Index, I'd like to just cover a few key aspects of the tool. Those being first and foremost, that the WI is for healthcare workers specifically. It's the main reason that we have it 100% anonymous. We just feel that that's so important, that it's a third-party tool, and we really want to remove the fear of self-assessing and just make it part of their career, from med student to resident to physician, and really remove the fear of the implications of not scoring well, because there's this stigma that the doctor shouldn't be sick. And we want to remove that stigma and give them a place that they can do that. And essentially, if they don't score well, we want to provide them with just-in-time resources to hopefully begin their journey towards improving their well-being and removing that problem from their life. So with that, I'm going to hop out and I'm going to show you the Wellbeing Index in action. I'm actually first going to show you the experience of the WBI from the vantage point of a physician. And then I'm going to show you after that what the back-end de-identified aggregate reports look like for an institution. So there are several ways that we can actually send out an invite. This is a common invitation here of what it looks like when we would initially invite somebody to the index. And this would be crafted by your organization and us. And it highlights, again, some of the common features. It's 100% anonymous, their score is private, and it will not be shared with the institution. And then essentially there's a link and an invitation code, which will immediately take them into the sign-up screen, which looks something like this. And I'm going to just go through here and show this to you. So they need to enter in an email address. We require that so that we can actually send correspondence back to them. But it's important to note that they don't have to use the email address that's provided by their institution. If they would like to use an anonymous Gmail address or Hotmail address, they can use that. So it's completely separated from the institution if they'd like. We ask them some basic demographic questions, such as their gender and the year that they graduated medical school. And we also ask them for their specialty. So in this case, I'll just choose emergency medicine. And they are also asked for a state. In order to create an account so they can track their well-being over time, they must enter in a secure password. And we also ask them how often they'd like to be reminded to come back and reassess. Now, they can actually reassess as much as once per month or every 30 days. But maybe they don't want to be reminded every month. By far, most people leave this at every month. Our goal is hopefully that they will leave it at that, and they may miss a reminder or two because they're just busy. But hopefully, we would get an assessment, say, every quarter. They can also input their cell phone number to be sent text messages. And we'll talk a little bit more about that a little bit later. Once I agree to the terms, I hit proceed. I'm immediately taken to the 9 questions. So these are the questions that encompass the Wellbeing Index. During the past month, have you felt burned out from your work? During the past month, have you worried that your work is hardening you emotionally? During the past month, have you often been bothered by feeling down, depressed, or hopeless? During the past month, have you fallen asleep while sitting inactive in a public place? During the past month, have you felt that all things you had to do were piling up so high that you could not overcome them? During the past month, have you been bothered by emotional problems such as feeling anxious, depressed, or irritable? And during the past month, has your physical health interfered with your ability to do your daily work at home or away from home? And then we ask 2 additional questions, which are on a sliding scale here. The work I do is meaningful to me, and my work schedule leaves me enough time for my personal family life. And down at the bottom here, we also have a section that tells them, wait a minute, how can they actually assess my well-being? with these simple questions. And we actually go through some of the validation that's been done, peer reviews that have been done, and give them assurance essentially that this is a validated tool. So once I submit the index, you'll see that I didn't do very good. You will see that this flag here depends on how you answer the questions. And you'll see the risk of your mental health adversely affecting you personally and professionally in the medical profession is high. We strongly encourage you to seek help from a professional mental health provider. So depending on how they score, this may or may not show up. Obviously, the physician assistance program would be the number at your institution. And then we give some other resources here that they could talk to. Everyone will see this section here. It will tell them their well-being index score, and they can click on the link and it'll show them, okay, here's where I just scored. The national average is here, and my organizational average is scoring here. It also tells me that I'm lower than 70% of US physicians, and it tells me that I'm lower than 52% of physicians at my organization. So again, they can see that same chart and they can see how they're scoring to their peers at the same organization. Then we show them 6 different categories, these charts here. Essentially, it's their sense of meaning in work, their likelihood of burnout, their severe fatigue, suicidal ideation, their risk for medical errors, and their work-life integration. So each one of these can also be clicked on, and will show more information about the study and how they compared to their peers. In this case, burnout in US physicians, there was 6,445 were assessed using 2 items from the Maslach burnout inventory. So they can see some how their scores are actually correlating to studies that have been done up to this point. At the bottom of that, or underneath that, we actually show them 4 categories of resources here. You'll see that essentially not all 11 categories showed up. We display these categories based on how they answered the questions. So these 4 that are showing here being recommended to them will change based on how they answer the questions. And I'm clicking into one category here, and I'll just give you an overview of how this is. Obviously, there's that video that we mentioned. Each section has a video that talks about the topic and how it relates to whatever version that they're in. And we also have your local resources would be in here if you license the tool. And then we have additional national resources. So there's also, could be links that you could download, could be websites that you could visit. And then obviously at the bottom, we also have key publications that talk about this topic, and we link out to various JAMA articles and things like that. One thing I forgot to show you, I will go back here real quick to my dashboard. We can also, actually I need to click out to the demo here, 1 second here. One thing that's important is we also allow them to see their well-being over time. So up in the upper right here, they will have literally every time that they have assessed, and it will show them that the scores that they had gotten. You see here they were average, but they can choose this selection here, and it'll actually show them their well-being over time. So they can say, hey, when I reassessed back here, when I first started, I was average, and now I'm really slipping and I'm not doing as well as I used to. Why is that? What is it about my day? What is it about my career that I'm no longer as excited about? Finally, one other thing we allow you to do, I think it's just important to share it, or at least tell you about it. We allow the physician to enter in their name and check the dates that they have assessed, and they can generate a custom certificate like this. So they can actually, we're encouraging a lot of institutions to incentivize participation in the Wellbeing Index, and they can turn in a certificate like this to prove that they have participated. And then what you do, you could give gift cards, you could give discounts on insurance, you could give, things like that to, to be able to encourage them to participate. And then obviously we just have, other than the dashboard, the transcript, we also have lots of articles of research. And we answer those common questions like, how can we actually determine the well-being with only 9 questions? And we also link out to a lot of different PubMed articles and things like that that dealt with the validation of the tool, how it was validated, and what was done over that time. All right, so with that, I'm going to flip over, and I see that I'm going to pause here for just a second. I see that we have some questions coming in. I encourage you, as I'm going through here and talking, we are going to leave some time at the end to try to answer as many of those questions as we can for you. I encourage you, do that as you think of them as I'm talking here. Feel free to fill out that Q&A and ask some questions. All right, so that's essentially the experience that would be seen on the physician side, or the nurse side, or the employee side, and this is the view that would be seen on the admin side. So as I mentioned, we allow you to get access to de-identified aggregate reports so that you can get a feel for how your physicians are doing. Obviously, the top report here is percent of physicians with a high level of distress. And we always show you how your physicians or your residents are comparing to national averages. So you'll be able to see your percent of at-risk scores compared to the national average. And we do that, you might have remembered in the demographic question, we asked how many, what year did you graduate medical school? So we know essentially that, and we can gauge their age from there. We also show you some graphs on the percent of physicians that have signed up. We also show you that in the same thing, but signed up over time. So we encourage you to do several pushes to the invite. They may not do the first time, but if your leadership is committed to the program, you will continue to get people to come on the second, the third, especially as they hear from their peers more and more that they have participated. Percent total number of physicians that have assessed, mean score compared to the national norm, mean score of your physicians over time, mean physician well-being index score by gender, so how do your male versus female, and mean score by specialty. So I'm going to click into this one actually, because each one of these you can actually get even more information about. In this case, we are reviewing mean score by specialty. You might have remembered when I first signed up, I was asked what my specialty was. And here you will be able to see all of your specialties and how the mean scores compare to each other. Important item to note, we do, in order to maintain the anonymity of the tool, if there is ever in any one of these categories less than 5 respondents, we will not show you that data. So as you can see here under pediatric surgery, it says sample size too small, there's less than 5, but we do tell you that there has been 4 that have participated in that category. All of these charts can also do some other, there's line charts that you can see things, you can toggle on and off different specialties, you can filter by week, month, year, and you can actually even select a date range. So we allow you to select a date range so that, of course, as you implement wellness programs, you can hopefully go back and say, how does today compare to 6 months ago compared to a year ago? So hopefully we can provide some meaningful data to you as far as how they're doing and how they're changing over time. I'm just going to go back here real quick. So the other reports we show you is mean score by year since graduation, physicians resource they accessed. I mentioned that one as far as which sections are they most commonly clicking into and watching videos and things like that. And then the email performance for invitations. So how are those emails performing? I should mention too, alongside with the basic demographic questions that you saw when I first signed up, things like male, female, specialty, year that you graduated, we also, when you license the tool, we allow you to ask up to 3 custom demographic questions. So we do that so that you can ask things, if you have a lot of locations, you can ask a question like, which facility or which location do you most commonly practice at? And then that would automatically give you a mean score by locations report. On the resident version, a common question is, are you a resident or are you a fellow? They like to separate out their residents from their fellows. On other versions, they may want to know what specific program that they're involved with. So our implementation team would typically work with you to figure out the best way that you can segment your data and how, to be meaningful to you, and make sure that we're asking those custom demographic questions so that you can get those mean score reports. There's a whole lot of other features in here that I'm not going to go into detail during this webinar, but just know that you can also manage admins. A common question we get is, how many administrators can I have at my organization? You can actually have as many administrators as you need to have access to the tool. So you can, we also have the ability to have them just be reporting admins or full admins. Full admins can do things like manage the resources as far as editing, which categories, uploading files, things like that. Or you could give, say, a chief medical officer only access to view the reports if all they wanted to do is be able to see the reports. So you have the option to do that. I mentioned the sign-up questions. Again, you have the option to add up to 3 custom demographic-based questions. And all of these things can be actually done within the back end. One other important item to note is we give you, throughout the tool, we give you the option to customize a lot of things. So we'll give you the option to customize the invitation email, reassess the reminder emails. So we want it to appear as much that we want them to know that the institution is behind this too, and that it's not just a third-party tool, but we're actually working with you and working on behalf of you to promote this program. So we'll give the ability to customize a lot of those things and make it easier for you. All right, with that, I'm going to hop back out, and I'm going to talk briefly here about the different options that we have for you to get involved with the Wellbeing Index. The first and foremost that we offer is our free plan. And we offer a free plan because we want it, whether or not the institution has us in their budget, we want you to be able to have your physicians, your residents, fellows, your medical students to be able to come to us and assess. And so literally, when you sign up for the promoter plan, you'll have the same tools that available as a licensed version was. You won't be able to do some of those customizations, but your physicians, your residents can come to the website, they can sign up, they can track, they can get a score, they'll be created an account, they'll be reminded to check their well-being over time, and we'll give them access to the same national resources that we give those who license the tool. So it's a great way, as some of you, maybe from residency programs, that the AC GME has, some new common program requirements, Section 6, that say that you must provide some sort of tool. We want to give that tool to you so that you at least have a baseline for beginning the discussion and beginning to have your residents assess. So that is why we offer a free version, and we encourage anyone, whether you're in our budget or not, to at least sign up for the promoter plan so that your physicians, your residents can participate. The first plan that we have that's considered a licensed plan is what we call the advocate plan. And essentially the advocate plan gives you everything that I just showed you on the admin side as far as those reports. It gives you access to those de-identified aggregate reports. It also allows you to put in your own custom local resources. So things like your EAP number, we now know that they should be associated with you. And our team really is going to assist you in the implementation and the rollout of the package. There's a lot that goes into preparing for a launch of something like this, as far as how you communicate it, and the communication that you do before you even send the invites will definitely impact the percent of physicians that are going to participate. So we also do that for you, and we help you roll it out in a successful manner. I mentioned, you can see there, this plan starts at 10,000 setup and an annual license of 5,000. That actually 5,000 annual license includes up to 5,000 participants. So we encourage you to license the tool across multiple versions instead of just, say, one small residency program. The third plan, and this is the final plan that we offer, is called the Champion Plan. And it includes everything, obviously, in the promoter plan and the advocate plan. The big difference here is we're rolling out some new features, what we're calling the advanced reports. And with the advocate plan, you'll have a report of, say, mean score by facility. We mentioned that, mean score by location. But what you can't do is really create custom reports. For example, you can't say, can you show me mean score by this location, but also emergency medicine facilities. So with the advanced reports, you can create any sort of combination of custom reports. You can build them on the fly, and they will show you real-time data. So that is part of what we call our Champion Plan. The other thing that we are doing with the Champion Plan, and this is going to be rolled out in the very near future, is process improvement type surveys. So after they have assessed their well-being and see where they're at, we want to also ask some additional process improvement questions, such as what is one thing your institution could do in the next 6 months that would improve your overall well-being. And we want to collect data like that so that we can provide it back to the institution and give you a starting point for opening that communication with either your physicians or your residents. So when you go out and you go to those communication channels, you already have some information that you can start and you can work with. And then obviously the third thing there in the Champion Plan, we have a mobile app that is nearly completed. And that is going to be offered first and foremost to our Champion Plan members so that they can, those physicians, those residents, medical students can simply assess right from the mobile app that we deploy. And we feel it'll be much quicker, much easier, and will increase the number of assessments that they are doing on a daily basis. All right, I've mentioned this a couple times throughout. We have 5 versions of the Wellbeing Index available for licensing: the physician version, the medical student version, resident fellow version. We have an employee version and a nurse version. We are in the process right now of developing and tracking the data on the NPPA version for those advanced practice providers. And we expect that to be released late 2017 or early 2018. So we have many different versions. You can actually, when you license the index, you can use one or more versions. As I mentioned, the initial setup fee of $10,000 includes one version. If you wanted to deploy multiple versions, you can add additional versions for an additional $2,500 one-time setup fee. And so that annual license fee can span multiple versions. It doesn't need to be just one. Since we started a minimum of 5,000 participants for licensing, it obviously is most advantageous to roll out the Wellbeing Index across the entire institution. But as I mentioned, if licensing the tool is not in your current budget, we always encourage everyone to start on the promoter plan so your physicians, your residents can begin assessing. You can always license the tool at a later date, and we then have de-identified aggregate reports available to you whenever you happen to upgrade to the Advocate or the Champion plan. Another common questions we get is who is using the Wellbeing Index? This list here is by no means complete. We've just recently started asking permission to use organization names in our list for marketing purposes. In fact, in the last 90 days or so, we have licensed and implemented the tool to over 25 new institutions. So, and obviously many more than that have signed up under our free promoter plan. They're just getting started, and hopefully in the future they would, be interested in upgrading to our Advocate or Champion plan. All right, with that, it looks like we have about 20 minutes left, and we probably won't use all that time for questions. But I'm going to, I see that there have been quite a few that have come in here since we began. So we're going to, John, I think I'm going to open it up to you, and maybe you can see what has come about?
Absolutely. We got a lot of great questions coming in. So we're just going to go down the list here. I've answered a few of you by text. So hopefully you've seen those answers. And we'll just try to get through as many of these as we can. First one, is there a way an institution can track individual participation, completed or not only, nothing about the response?
Yeah. So you know that you will not actually know exactly who is participating and who is not participating. So that's part of the whole de-identified aggregate part. Now, the only way you would know, we get this often. I want my medical students to be forced to do this. So we always say to that, we don't even always know who they are. You may have noticed when I went through and I completed those demographic questions, I was never asked my name. And my email address could have been a completely anonymous email address. So we may not even know exactly who they are. But if you required them to print off that transcript, say once a year, or maybe it's during their annual review or whatever you wanted to do, but if you required them to do that, you would then be able to track and know who is actually participating and who hasn't. But as far as a way to do it within in the application itself, no, simply because we may not even know who they are also.
Awesome. Do you have any plans to include or separate out nurse practitioners and PAs for that version of the Wellbeing Index?
Yep, we kind of touched on that briefly. We do have a version. So what we're doing right now is essentially we do have some groups who want to survey, their advanced practice providers. We've accommodated that presently in the employee version. And we actually ask them a demographic question if they're an NP, a PA, with the intent that, because again, we don't have those customized videos and everything done just yet. So if you really wanted to start there with surveying your PAs, we're using the employee version. And we ask a demographic question to segment them by NPPA, so that once that version is available, we will automatically migrate over those users to the proper version, and then essentially that they would automatically be converted over into the NPPA version.
Awesome. Yeah, and kind of going along that line, we have another one that's asking about can I differentiate between residents and faculty?
Yeah, well, you could do that through a couple different ways. If you only had one version, you could ask a custom demographic question that would do it. But typically, residents we would typically invite to the resident version, and faculty we would invite to the physician version. So they would automatically, if you did that in such a manner that they were separate versions, you obviously know that your faculty is in the physician version and your residents fellows are in the resident version. So typically that would be separated by the version that we deploy for them. But let's say you had to do it all under, say, the physician version, you would need to ask some sort of custom demographic question to be able to segment the data that way.
Is there a way to remove an individual from an institution's database, or can a person remove them, or does it have to be the person themselves to remove themselves from the system?
Great question. We also have a different scenario too that we're addressing right now. But essentially, what do we do when somebody graduates from medical school and now they need the resident version? And what do we do once they become a physician? How do we migrate them to that version? So we will begin very shortly here, prompting participants to confirm that they are still with an organization or that they are still a resident. And so we will prompt them when they log in and have them confirm some basic demographic things so that we can either graduate them to the next version or deassociate them from an account. The other thing that we've done too is allow association of a physician with multiple accounts. A common scenario there is, the American College of Surgeons invites them to participate, but then they are also a physician at Johns Hopkins, and how can we make sure that they get included in Johns Hopkins data, but also they are included in the U.S. College of Surgeons account too. So we have some correlations like that we're now accommodating so that we can graduate and move people up and also associate them with the appropriate accounts.
Excellent. Let's see here. Are you able to export the data for further analysis?
So you can export reports, but you cannot export the data. And we do that for the main reason you cannot simply export raw data is for that anonymity factor. Obviously things like male, female, and some of these specialties where you may only have, one or two certain types of surgeons, if we gave you access to the raw data, the anonymity factor. But as far as the reports that you saw there, those are able to be exported as PDFs, and you could then download them and essentially send them to leadership or whoever you wanted to send them to. So that is the current flexibility with exporting.
Perfect. And how many unique users are supported on the Advocate plan?
Good question. So the Advocate plan, you may have noticed, starts at 5,000. So that would allow you up to 5,000 participants. So we base our licensing based on the number of employees that you have. If you have less than 5,000, which many of you will, we basically start our basic package starts at that $5,000 a year level. So regardless of whether you have 4,800 or you have 150 physicians that you would like to survey, our base packaging for licensing, because setting up the account and custom resources and deploying it across an institution is at that level. So you can have up to 5,000, and that can go across multiple versions. So could be across residents, fellows, nurses, general healthcare workers. So we really encourage you to deploy the tool across all aspects of the organization and not just one faction.
Awesome. And so here's a question too. If you begin in the promoter plan, do residents or participants still get a certificate if they participate?
You bet. Yep, they still can. The transcript feature is available across all versions, so they could still go there. They have that option is available, and they can enter in their name, and they can print off a transcript and do whatever they would like with it. So yes. The other thing we do, I guess I should explain this a little bit further, but on the promoter plan, there's a certain URL that you would send them to, and along with the demographic questions, we also ask them. For example, the resident version, we ask them then, which residency program are you associated with? And we have a list of all residency programs in the United States that are in that drop-down list. So if you were to eventually license the tool later, we would have already associated those residents with your account. We do the same thing if they're a physician. We have a list of all of the most common hospitals that they may be employed with, and they can indicate which hospital they are associated with. Now, we always encourage people, there's a list, actually, if you sign up for the promoter plan, there is a way for you to be able to search those two lists for residency programs and search a list of hospitals to make sure that your organization is on the list, because the last thing we want to do is have a lot of people sign up and it's not associated to any sort of account that we can later, if you want to license the tool, provide some sort of meaningful data to you. So good question.
And you mentioned that there's the ability to start at a lower level like the advocate or the promoter level and then jump up to the next level as it becomes necessary. Can you also move down one level? So maybe start at, say, the champion level and then decide to move down to the advocate.
Sure. Yeah. Good question. Yeah, we actually are very flexible on that. We'll let you move up, down. It's very common for an organization to start and say roll out with all their residents because they have somebody that's really excited, in that space and wants to get rolling. So we may start with the residents, and then 6 months, 9 months, a year later, they're ready to tackle the physicians or they're ready to tackle nurses. and they're ready for that next version. And then we simply we do an addendum basically to the standard license agreement that we do to add that version, and we help you deploy it, and we help you roll it out to, say, the nurses then, and you're up and running. So yes, I don't envision this like it's you have to decide today what you want to do with everything. We encourage you to get started small or as little as it makes sense for you, and upgrade later as it makes sense, and you have the bandwidth to tackle it.
Perfect. And does the medical student version distinguish between preclinical and clinical students?
No, not right now. I mean, as far as the mean scores, it does not. If you wanted to, again, you could do that with a custom demographic question. If you wanted to ask that question to separate the two, you could. But as far as the the mean score that we're comparing them to right now, no, there is no difference.
Perfect. That looks like we've pretty much got all of the questions asked. One question we do also get sometimes is, some of the indices have a nine question index. Some of them are 7 questions, and maybe you just want to go through why there is that difference.
Sure, that's another great question we get. Yeah, there's you're right. When we first started the index, everything was a 7 question index. The resident version and most of the versions are 7 question. The 9 question on the physician version actually came about to help assess the essentially career satisfaction. Those 2 extra questions that we're asking really get to not necessarily burnout, but how satisfied are they in their career and their career choice. So those additional 2 questions are really getting more into like work-life balance and work-life integration than just, burnout or suicide or depression. So those went to a 9 question index, where obviously it doesn't make sense for, say, a medical student to be yet assessing how satisfied they are in their career. So that's why some versions are still 7 and other versions have those additional 2 questions in there.
Perfect.
Excellent. Well, it looks like that is most of the questions that we had for today. So I appreciate all of you hanging in there with us today during this webinar. You will get a follow-up email that will give you a recording of this session. And it'll also include some information about how you can learn more about the WBI, or maybe if you're interested in signing up for the promoter plan or any of our other plans, it'll give you some links to do that. It'll also include a link that you can book a meeting with me. There on your screen, you'll see that I have my email address and phone number. Obviously, again, if you'd like to reach out, if you have additional questions, maybe you're shy today and didn't want to ask a question, no question is too silly, so feel free to reach out. We'd love to make ourselves accessible. So with that, I thank you for joining us today, and hope you enjoy the rest of your day and this weekend. Thanks now.